Hi, my name is Kirsten Berggren, and I would like to present to you a lecture about menopause hormone therapy, specifically about clotting risk and specifically about oral hormone therapy. But first, I want to tell you a little bit about myself. I am a nurse practitioner who has a PhD in anatomy and neurobiology, and I have always been a teacher as well as a clinician, and I am certified as a Menopause Society certified practitioner. And my friend Sarah Sheely and I started the Meno Medicine Essentials course at the Meno Learning Lab because I feel very strongly that as women are becoming more and more educated about menopause and about the various treatments that are available, it's essential that we have providers who are educated so that these women can find somebody who can provide them confident and competent menopause care during their midlife transition. And I feel that the best use of my time and my skills is to create these courses and hopefully share out the education as incentive. We have built this as a CME course. We currently have about 6.5 hours of CME available. We're going to be building to a full 14-hour course that will really provide you soup to nuts, everything that you need to know to be a fully competent menopause provider, and we also use this as a study guide for the menopause certification exam for people who are interested in taking that. But it's not just for those taking the exam, it's for anyone who takes care of midlife women in their practice, and that's an awful lot of people. So that's a little bit of an introduction about me and about why we have the Meno Medicine Essentials. And let's get into it. Let's talk about understanding the risk of oral hormone therapy. We're going to be looking specifically at the risk of VTE or venous thromboembolism, stroke, and pulmonary embolism. And why are we doing this? Well, let's talk about a patient that I literally saw a few days ago. We'll call her Janelle. She's 48, but she's about a year out from her last period. Her BMI is 33, but she's extremely active. She's a ski instructor, a hiker. She leads a very active lifestyle. She eats a healthy diet. And up until now, she hasn't really been limited by her weight. She's always struggled with her weight, but she's always been able to do the things that she wants to do. She has a strong family history of obesity, diabetes, and especially hyperlipidemia, and recently got an elevated LP little a, raising concern for her about the risk of heart disease. And her weight has increased at this point to a place where she's no longer comfortable doing the things that she wants to do. And she has found some limitations due to her weight. So she is most interested in optimizing her lipids and her glycemic control, as well as hopefully getting some help with her weight. But she's talked to her friends, and they're all super frustrated about how hard it is to get a patch these days. And I fully understand that myself. I recently just switched over to oral estradiol because I am an impatient person and I can't be bothered to be running around town going to different pharmacies. So hopefully after watching this lecture, you'll feel a little bit more confident knowing which of your patients it's okay to switch over to oral to hopefully get a little bit of a buffer until this patch shortage is resolved. So why would we want to do oral estrogen? Well, it turns out that because oral estrogen goes through this first pass effect in the liver has a higher exposure to estrogen than other tissues. And as a result, it affects the liver metabolism of lipids, resulting in a lower LDL, a higher HDL or good cholesterol, and this is what's really fascinating to me is it lowers LP little a by up to 25%. And we have not found anything else that will move that number, which has been thought to be a static genetic number. But it turns out we can move it with adding estrogen therapy after menopause or even during perimenopause. Uh, Oral estrogen has shown some improved glycemic control compared to transdermal. We don't have conclusive head-to-head studies on this, but the studies that showed a lower type 2 diabetes risk with estrogen were all done on oral estrogen, and it lowers the diabetes risk by about 30% as women go through menopause. Oral estrogen also improves insulin resistance in the liver, reduces the liver production of sugar, and helps improve liver uptake of glucose from the bloodstream. There's inconclusive evidence, but some initial evidence that with oral estrogen, you may get some improved action of GLP-1 medications. This is also true, probably to a lesser extent, of the transdermal. And there's some preliminary evidence that maybe we get some additional metabolic benefits from oral estrogen, including improved weight control and obviously the patch shortages. So why would we not give oral estrogen? Well, the big one is the increased risk of blood clots, increased risk of venous thromboembolism, pulmonary embolism, and stroke. And in the literature, you'll find anywhere from a 1.5 to a four-fold increase of the risk of a clotting event with oral hormone therapy. That risk goes up 10 to 20-fold increased risk in somebody with obesity who is put on oral hormone therapy. And there is no increased clotting risk with transdermal estrogen. This has been shown over and over and over again in multiple studies that the transdermal does not carry this increased clotting risk. And another downside of the orals, in spite of the fact that they improve the overall lipid profile, you do see some elevation in triglycerides. So, what we need to really be thinking about, and this is where I find statistics and numbers to be fascinating, we need to look at how much is that increased risk. Like we say it's 50% more or four times more. Well, we have to know more than what. What are we coming from as a baseline? This is a paper that was published in Menopause in 2018 that really showed a lot of this increased risk and did a head-to-head comparison of ETS, which is the estradiol transdermal system, excuse me, and oral estrogen. A downside to this study is that the type of oral estrogen was not specified, so we don't know if it was conjugated equine estrogen or estradiol, which will be important as you'll see in a minute. And the odds ratio, so this is the statistical chance of making a change for transdermal versus oral, was a 0.72, which is about an 18% reduction in risk. So we see here in this graph, we have this solid line that shows the oral estrogen. The dashed line that's the transdermal definitely looks like quite a bit less risk. But an important thing that we have to do is we have to know what the y-axis is. And so that's what we're looking at in terms of absolute risk versus relative risk. So after 2 years, the risk of a clotting event with oral hormone therapy was 1.1%, so about 1 in 100. And the risk with transdermal was about 0.7, 0.68%. And so it doesn't mean that the oral hormone therapy gives you that entire 1%. What it's giving you is the difference between 0.68 and 1.1, which is about a 40% increased risk in this study. So you see how you really have to know where you're starting from, where you're getting to, and this understanding can be a little bit elusive in the way things are presented. Also, the progesterone makes a difference. The highest risk is with what are called the norpregnanes, which include norethindrone and medroxyprogesterone acetate, which is MPA, which is the form of progesterone that was used in most of the studies with the Women's Health Initiative. And that's our largest study body to date. The lowest risk is with micronized progesterone, which is the one that we're most commonly using now, and something called dydrogesterone, which unfortunately is not available in the US. So, what are we starting from? What is the baseline risk of a clotting event? And in women age 50 to 60, it's about 2 in 1,000 person years. So, what does that mean? It means that if you follow 1,000 people for a year, you're going to have about 2 clotting events. It also means if you follow 100 people for 10 years, you're going to have about 2 clotting events. Clotting risk increases with age. So in women between 60 and 70, that risk doubles. And so now it's about 4 in 1,000 person years, which is still a pretty low risk. And I will say that as women age, I definitely make a switch from oral to transdermal, and I try to get everybody onto transdermal by about age 65. But what are we doing between 45 and 65? And that's what I'm really talking about. So the cumulative risk, so this is the complete total incidence of a first clotting event in women, 2% will have a clot by the age of 50. And then after menopause, it becomes more likely. So about 4.3% will have one by the age of 70. If you do the math, that means that 2.4% of women, so two and a half out of 100, develop their first clot between the ages of 50 and 70. So let's dig into this a little bit more. This is a great study by Vinogradova and her colleagues published in the British Medical Journal in 2019, the use of hormone replacement therapy and risk of venous thromboembolism from these massive databases, the Q Research and CPRD databases, which they initially found about 80,000 women who had had a venous thromboembolism between 1998 and 2017, so almost 20 years. And they were matched by age, BMI, smoking status, cardiovascular disease risk, and many, many other factors, socioeconomic status, race, and they were matched with 391,000 controls. So now we have the women who've had a clot and the women who didn't have a clot, but how many of them were on hormone therapy? And out of that group, they found 5,700 or almost 5,800 women who had a venous thromboembolism and over 21,000 who did not. So those are our controls who'd been exposed to hormone replacement therapy within 90 days. And we're using that as a guesstimate of that they had been on hormone therapy for some consistent amount of time before they had their clot. And what I find is really interesting is that this comparison of risk really differentiates between the different forms of estrogen. And this is something that is frustratingly lacking from so many of the studies. They'll just say estrogen hormone therapy and estrogen and progesterone without specifying what kind of a progestogen they're using. So this study breaks out the risk between conjugated equine estrogen and estradiol. And what you can see is that we have about a 50% increased risk with CEE, or conjugated equine estrogen, and just over 25% risk with estradiol. So the estradiol cuts that increased risk in half. And then when we look at combined hormone therapy, so now we've got estrogen with a progesterone or a progestogen, which is the name for the broad category. And we can see that this is our highest risk right here is the conjugated equine estrogen with medroxyprogesterone acetate or MPA. And in this study, they found that risk to be over 2, so over twice as much of a risk. A little bit less when you switch to a norgestrel progesterone, but when we combine the same progesterones with estradiol, again, that risk comes down. So the risk is highest with the MPA. This dihydrogesterone that we don't have access to here is lower than estradiol alone. We're more likely to be using like norethisterone or the norgestrel or drospirenone, which have risks that are a little bit higher, but not as high as the conjugated equine estrogen. Here again, we can see that transdermal, no increase of risk. And we can't say that this is a decreased risk, even though they're below to the left of this 1.0 line, which is the baseline, because the little bars, the range crosses 1. But it looks pretty good for transdermal estrogen. And then they also looked at a couple of other estrogens, hormone therapies. Tibolone raloxifene is a SERM, a selective estrogen receptor modulator that is used for the genitourinary syndrome of menopause. So they also compared dose. I love this. I love getting in the weeds on the data like this because it really allows me as a provider to make an informed decision and help my patient make an informed decision. So obviously what we see is that as the dose goes up, the risk goes up. CEE, this is the standard dose, 0.625. Once you get over that, you've increased your risk by quite a bit, going from 40% to 71%. Estradiol, once you get over 1 milligram, you have a similarly increased risk, but it doesn't increase by as much. And then when we go to our combined therapies, a high dose CEE is going to be about our worst case scenario. And there we're approaching a threefold increase in risk. Here we see estradiol with different progesterones and estradiol above and below that sort of index dose of 1 milligram, which is about the standard dose. And again, with the higher dose, like we can see here, estradiol over 1 milligram, even with this very protective dydrogesterone, we get a 30% increase in risk. And then with transdermal hormone therapy, once you go over that 50 microgram or the 0.05 milligram patch, you are going to see some increased risk, but again, it crosses that line of 1, so we can't say increase or decrease. Hopefully that makes sense. The higher the dose, the higher the risk, and just explaining how we come to that conclusion. They even did direct comparisons between different hormone therapies. So they did them head to head. So oral versus transdermal. This is one data pool. This is another data pool, the CPRD. And when we combine these, we see that the oral has a 70% higher risk than the transdermal. When we look at our best case versus our worst case, so the estradiol with dydrogesterone versus the CEE MPA, we see that we have half as much risk with the estradiol combination. And I bring this up and I want to include the CEE because if you're ever prescribing Duavie, which is a fascinating medicine and one that I think we're going to be using a lot more of, it combines estrogen with a SERM or a selective estrogen receptor modulator that blocks estrogen activity at the breast and the uterus. So this is an estrogen that you can give to women who still have a uterus and they won't need a progesterone. What's in the hopper right now in terms of research, this is so exciting, is that it blocks estrogen activity at the breast. And no one has come out and said this reduces the risk of breast cancer in a high-risk patient, but that is being very actively worked on right now. So watch for those results. But if you're prescribing Duavie, it does have conjugated equine estrogen for some unknown reason, but that's the form of estrogen that's being used. So if you're going to be prescribing Duavie, you really need to be thinking about also what are my increased clotting risks with the conjugated equine estrogen. So let's look at this in context. What are other things that increase clotting risk? Obesity is the big one. So fully a third of what we call idiopathic VTE, so an unprovoked clot. And we call something a provoked clot if we can figure out why it happened. You took a 7-hour plane ride. You were inactive for a long period of time. You had a surgery. You had pneumonia. Those are all considered provoked. But of the unprovoked clots, which are the scarier ones that kind of come out of nowhere, fully a third of those are related to obesity. And so if we look at this OR, which is odds ratio of 2.3, that means if you're obese, you have a 2.3 times increased risk of having a clot on just from being obese. That's not even adding any hormone therapy. And this odds ratio, or also sometimes it's called an HR harm ratio, really means the same thing, is even higher, 2.7 if the BMI is over 40. So other things that increase risk, current smoking, we have a 20 to 50% increase in risk. Physical inactivity, we can kind of flip this around backwards and we've got about a third, about a 13 to 35% increased risk with physical inactivity. And this is a reason for a number of our clotting events, and these are preventable with just the minimal activity. Active cancer, obviously, this is a huge risk for blood clots, and that's a whole different story. Hospitalization or surgery, acute infection, like I mentioned, if you have pneumonia, you have almost a 5 times increased risk of having a clot during that infection. Inflammatory diseases like inflammatory bowel disease or autoimmune disease, those increase the risk, and lupus increases it the most. It's a 15-fold increase. Diabetes increases your baseline risk, and obviously genetic factors are going to factor in. Frailty doubles your risk of a clot, and guess what helps prevent frailty? Estrogen hormone therapy, because it helps with our bone density and it helps with our muscle mass. So let's put this in a visual form. I'm a very visual thinker and I love when I can put something in a graph. So let's look at our risk of venous thromboembolism. Here we are at baseline. This is a person who's not on hormone therapy, and this is someone who's on transdermal. It's the same. I made it 2.1 just to put a different number there. Here we have overall oral hormone therapy. We've doubled the risk, so we've gone from 2 to 4. And with CEE MPA, that our worst case scenario, we're up to 8. And this is, sorry, I forgot to give the units here. This is the risk per 1,000 person years. So here's our baseline, 2 per 1,000 person years. Well, that looks scary when you look at it like that, doesn't it? It looks like, wow, this is a really high risk. But what's on the y-axis? Well, we have nothing to compare this to. So I like to put in some other things and that we have some sense of how common they are. So I've added in the risk of food poisoning. This is our tall bar right here. So 160 per 1,000 person years. So if you followed 100 women for 10 years, you would have 16 cases of food poisoning, maybe more right in this moment because we're having this bacterial infection with the Taco Bell lettuce that's giving people massive explosive diarrhea. But anyway, this is your baseline risk of getting food poisoning. Down here on the green bar is our risk of being in a car accident. It's 50 per 1,000 person years. So if you watch 1,000 women for a year, you're going to have 50 car accidents on average. 16 over here is the risk of developing diabetes over age 50. But again, remember, diabetes itself increases the clotting risk, but oral estrogen therapy reduces the risk of developing diabetes. So you can see how we really need to take all these factors into account. And I also put the risk of having a heart attack between 50 and 60, and that is the same risk as that of having a blood clot, 2 per 1,000 person years. And I just want to put in another way to look at this. So this is another way to evaluate the statistics. Find a way that makes sense in your brain. And this is looking at the extra cases. So now we're up another factor of 10. We're looking at extra cases per 10,000 people who've been treated with hormone therapy per year. And if we look at estradiol in all ages, we're looking at 4 additional cases of a blood clot per 10,000 people per year. If we look at, again, here's our worst case scenario, CEE MPA across all ages, 18. So 18 per 10,000. That's about 2 per 1,000. It's not a crazy high number. We need to keep these things in perspective. And then, I've listed the other things on here, oral hormone therapy in general, but this gives you an idea of just another way of looking at it. So, take home message here. Is the risk of a clot increased on oral hormone therapy? Absolutely. No one will contest that. But we really need to put this into context. And we're talking about something that is 2 to 4 per 1,000 person years. And like I said at the beginning, if we're limiting the amount of time that we have people on oral hormone therapy and moving them to transdermal by around age 65, which is when you start to see some significant increase in clot risk due to aging, and we consider all these other factors increasing risk. Obesity, inactivity, illness, inflammatory diseases, smoking, diabetes. And so if we go back to my patient Janelle, she has obesity. Her BMI is 33, 34, but she does not have inactivity. She's not a smoker. She doesn't have diabetes. And in having a conversation with her, we came to a mutual decision that she wanted to try oral hormone therapy. She is fully aware of the increased clot risk. We reviewed warning signs for a VTE or a pulmonary embolism. But I think that what she's really looking for is that cardiovascular protection, trying to bring down her LP little a, trying to get better hormone numbers, lipid numbers, and also trying to get better control of her weight. Now, because we know that a GLP-1 works better on women who are also taking estrogen, and that's from a new study that was published in Menopause last year, maybe we'll add a little bit of a GLP-1 once she's been on the hormone therapy for a little while and we can see how she's doing. But we're giving patients a truly informed decision, truly informed options. And when we talk about these shortages, access is part of treatment. So if you have somebody who is not going to be running around to different pharmacies to get their hormone therapy and is inconsistently on again, off again, take that into account because what we want is we want consistent treatment. And have a conversation with that woman. Maybe we could put you on an oral estradiol for a little while until the patch shortages are done, which most people are predicting is going to be within a few years. And then it won't even really be a consideration, but we also do need to be thinking about some of the benefits that can come from an oral estradiol. So these are the key references that I used. And if this kind of lecture is interesting to you, if you feel like you learned something, please come over and join us at the Meno Learning Lab and our Meno Medicine Essentials course. We would love to see you there. And thanks for your attention today.